All right, good afternoon, ladies and gentlemen. I know we've still got some people coming in the back, and they'll continue to get some food, and feel free, there's several seats here in the front. We would welcome you up front here. So, again, good afternoon. I'm Kevin Matthews, and I'm responsible for marketing at Elucid. And number one, thank you for joining us during your lunch today for what we think will be a very interesting panel discussion around our vision of CCTA 3.0, and specifically encouraging ways to look for ways to remove the blindfold, where we're integrating plaque biology and BioIntegrated FFR-CT for lesion-level assessment. Our panel today will be led by Dr. Amir Ahmadi from Mount Sinai Morningside. He'll be joined by Dr. Michael Hadley from Northwell Health, as well as Dr. Anton Kamaj, also from Mount Sinai Morningside. So without further ado, I'll turn it over to Dr. Ahmadi.
Thank you very much, Kevin, for that kind introduction. Do you guys hear me well? Do you hear me better? Should it come up further? The reason I'm asking is that I got this feedback yesterday that some people couldn't hear me from the back of the room, so just wanted to make sure. All right. So we're going to talk about what the current product of Elucid is, how we are envisioning the field, and what is our vision in terms of personalized care that we can contribute to in order to improve outcomes of patients. And the session is basically meant to introduce you to the technology, but also is an invitation for you guys to join us in this journey that we can do together. And we can definitely not do it without your expertise and your help and your feedback. So that's basically the overall intent of this presentation. And I'm going to talk about what we mean by CCTA 3.0 and what we mean by removing the blindfold in terms of integrating the different aspects of plaque biology and FFR-CT. The classic cardiology workflow in terms of coronary artery disease, even though we want to make it very sophisticated, it's not that sophisticated. If you think about it, those of you who see patients in clinic, we do 5 things. We either reassure patients or ask them to change their lifestyle or put them on some sort of medications or send them for further testing to figure out if they have ischemia, or send them to cath lab so Dr. Kamaj and his colleagues can help them with revascularizing. The way that we do that is usually twofold. Either we think about risk factors or we think about symptoms. And if you think about it, risk factors and symptoms classically have been the gateway to get there. And the reason that we do that is either to prevent heart attack or to relieve symptoms and improve the quality of life. So what's the problem with this? The problem is that it doesn't work. We did a study at Sinai that in the CCU, we looked at patients that came with their first heart attack. And the question was, if we saw these people that had their first heart attack 2 days prior to their heart attack in a clinic, according to ASCVD score or PREVENT score, or if we asked them about their symptoms, how many patients would be eligible for at least a statin initiation, and how many patients would be eligible or have indications for further testing? And the answer was, on the preventative side, about 45% will be missed by ASCVD, and these are the 45% that in 2 days ended up having a heart attack, 61% by PREVENT score, and about half of the people didn't have any symptom whatsoever, 54% in fact, on the day, up until the day of their heart attack. So the heart attack was the first symptom. So we can't really rely on that, and the field knows this. So that's why I think we are getting a different picture and seeing the evolution that we are approaching the whole problem of coronary disease differently. And if you think about it in a big picture manner, we are seeing that CCTA is helping with the phenotyping and risk assessment. Now we are going to this diamond that I would call, it's evolving to the diamond of personalized therapy that is trying to just not say the risk, but turn the risk into therapy. And the reason for that is that we want improvement in outcomes and fewer events. So the evolution started with a CT without any AI tool. And in that, if you had any atherosclerosis or plaque, that was an indication for medical treatment, although it's not the most granular medical treatment yet. But some things that is for sure is LDL should be less than 70, plus or minus anti-platelet therapy may be DAPT in certain cases. And if people have CAD-RADs of more than 3 and have symptoms, many physicians will consider cath lab referral for symptom improvement. In the past few years, we have seen the evolution of that to what I call a CT 2.0. And CT 2.0 is that when you add AI analysis to the CT scan to have either the overall plaque burden or FFR-CT. The overall plaque burden is definitely a consideration for prognostication. It's helping with the overall risk assessment, and it can help with guiding medical therapy. The problem with TPV, or total plaque volume, is that on its own, it doesn't take into account the individual lesion risk. Why is that important? About 20% of patients will have MI because of one lesion, and they don't have an increased total plaque burden. The total plaque burden is actually in the mild to moderate zone, and they have a single lesion without having diffuse atherosclerosis. So total plaque volume assessment will miss those. On the other hand, we actually don't have granularity in the data with regards to the effect of medications on plaque. We actually don't know if these medications that are listed and are suggested by many of the colleagues and many people that are here in this conference have any evidence on top of LDL reduction in terms of plaque stabilization. On the other hand, on FFR-CT side of things, revascularization is mainly for symptom, and FFR in a binary fashion at the end of the vessel is not the most robust guidance for anything aside from symptom in terms of event reduction, not invasively and not FFR-CT. And therefore, we think that there is a need for further evolving that to what we call a CT 3.0. So what are the differences between CT 2.0 and 3.0? Is now that we have the overall plaque burden, we actually have individual plaque features as well as individual lesion risk. We have to understand the effect of medical therapy on plaque. In that, we need to have a great algorithm for basically tracking plaque changes as well as physiological changes over time to feed back to that mechanism of personalizing therapy. And the guidance for what I call a overall envelope of localized therapy that doesn't just include PCI, but the emerging technologies such as DCB, BVS, as well as cryotherapy should not be just guided by physiology or morphology, by a comprehensive lesion assessment that includes all. And if I wanted to point out, if you draw a circle like that, that would be the personalized therapy circle. So the whole picture changes now in the middle diamond of personalized therapy that leads to improved outcome. And what you need to get there is reliable data. So when we talk about reliable data, what kind of data do we mean? And what kind of effect do we mean? The first one is accuracy. We had many, many years of discussions and debates in meetings like this, or TCT, or AHA, or ACC, about competing factors that are looking into plaque, into different assessment ways of plaque invasively, such as the ones that look at the anatomy, like MLA, MLD, or plaque burden, or physiology, or morphology, in terms of which is the best estimator. And now they are not necessarily competing anymore, they are complementing. Why am I putting this? This is basically referring to a famous poem by a 7th century Persian poet, Rumi, that talks about people going to a room and having a blindfold. And the question was to ask what you're feeling with your tactile senses. And everybody, as you see, is demonstrated in a different way. And then they remove the blindfold and they see elephant as a whole. I think as a field, it's time for us to remove the blindfold and see the lesion as a whole. That is not the components that are competing, but the components that are complementing. That is the anatomical features, that is the physiological features, and the plaque morphological features all together make a better lesion assessment. Now, in order to accurately predict that, or accurately putting together, we need to show that we have accuracy in each different department. So here we go. How does this work? We have this vision in our mind, in Elucid, to bring this conceptual framework to quantifiable reality. We had the CT 1.0, which shows a little bit of calcium, a little bit of non-calcified plaque, some stenosis. We apply Elucid. We see lesion detection. We see quantification of plaque. We see typing of the plaque that comes from histology, not a Hounsfield unit. From that, we can get a cross-sectional view with all the IVUS measurements of MLA, MLD, and plaque burden that has been shown in prospect trial that are very prognostic. From the plaque itself and vessel biology, as I will explain to you in a minute, we get the FFR. Not just the ischemia, likely or unlikely, but every point, a very accurate FFR along the vessel with a point value. We put the morphology, FFR, stenosis, and a bunch of other anatomical features together, and we come up with a lesion tool that, as you can see here, for every lesion, there is a full profiling and full phenotyping. And the result is a UI that you're seeing here that has the overall, for example, in this case, RCA, plaque on the top, the straight MPR in the middle, the FFR curve here, the lesion tool on this side, and the cross-section on the far right. So removing the blindfold, putting everything together. What is our accuracy like? So we divide this to different categories. So the first was the plaque accuracy. And we did this blindly in a completely independent lab that Dr. Aisha is here presenting these results today from London. And it shows very strong correlation on vessel volume, lumen volume, total atheroma volume, calcific and non-calcific plaque volume, as you can see. There was a best-in-class performance for that data set compared to 2 other companies and softwares with regards to necrotic core detection. And the reason for that is that our software is not Hounsfield unit based, but it is based on the learning from histology samples that it has and has a very high correlation with histology of 0.88. We also show an AUC of 0.8 when it's an LCBI of more than 0, and AUC of 0.74, whereas the LCBI of more than 400. With regards to stenosis, we recently had a validation study against 3 level 3 readers. In fact, Dr. Hadley was one of the readers that was blindly evaluating this as a level 3 reader and system director at Northwell. And what you see here is that on a patient level, the accuracy is sensitivity of 94, specificity of 92, and AUC of 0.98. Same on a vessel and territory level, 0.86, 0.94, and 0.96 AUC. But the category plus or minus 1 involvement or agreement is more than 93%, which is similar to any 2 level 3 reader inter-observer or basically expert agreement that there is. So it clearly shows that the stenosis product here is as accurate as an expert level 3 reader in the field. On the FFR-CT side, I'm not just going to talk about the results of FFR-CT, but talk about the whole concept of how we approach FFR-CT, which is called the BioIntegrated FFR-CT. It is not CFD model. We do not solve any equations. It is not ischemia likely or unlikely. It is actual AI model that takes into account full biological and physical properties of the vessel and lesion. What is the concept? The concept of biointegrated is that the coronary vessel is not a rigid pipe, it's a living organism. So it's important to know the physical property, but it's also important to know the behavior during maximal hyperemia. The vessel behaves differently depending on what type of plaque it has at the time of maximal hyperemia. So what you see here is that you have a calcified plaque that is about 70% on the left, and you have a non-calcified plaque with the LRNC and a positive remodeling on the right that is about 70%. On maximal hyperemia, this one fully dilates at every point, but this one, because of having Glaucovian limit, does not dilate in the middle, dilate on the side. Let me explain this a little bit better for you. So now is the resting that you're seeing. We're giving adenosine in the cath lab, and we go to full dilation. The top fully dilates. The bottom doesn't. Why? Because the positive remodeling here, and I scroll it back so you see it better, the positive remodeling here reach in the middle of the plaque for its maximal dilation capacity. So what happens here is that this remains stable and the two sides dilate, and therefore you create something in the middle called relative functional stenosis. Point is that the two type of plaque that started having the similar degree of stenosis, because of their different behavior at the time of maximal hyperemia, they have a different type of FFR. And you only can take that into account if part of your FFR deep learning algorithm has to do with the plaque type. Because the physical properties of that at rest, of these two, just based on the degree of stenosis or the minimal luminal area or any other type of physical properties, are the same. So also, it's a good reminder to say that FFR is not a direct measure of ischemia. FFR is a surrogate for ischemia at myocardium. What FFR does is differentiate between the pressure before and after a lesion, or at the beginning and at the end of the vessel, depending on where we place the guide. The pressure difference, as you can see in the slide here, is directly related to 1 over r to the power of 4. So if there is a relative difference in radius in hyperemia, your FFR will be completely different. And it will show as a positive FFR, even in a moderate case with a necrotic core with positive remodeling. This is not a new concept. This is a concept that I actually had the privilege of working with my mentor, Dr. Narula, over the past 10 years, and there are multiple publications on it. And if you're more interested in knowing more about this, please come meet with us after the session and we can go over the data and evidence. To illustrate what this means in real life, I give you 2 examples. So here you see a 37 millimeter lesion that is non-calcified, LRNC, and positive remodeling, and the other one, which is here, which is fully calcified. We applied Elucid analysis to both of them, and we applied BioIntegrated FFR. The lesion length and stenosis in both cases are the same. However, there is a difference between pressure drop between them. So as you can see here, both cases are about 50 to 70% stenotic. Both cases are 37 and a half in length. One case has a total plaque volume of 548, and the other one has about half of that. And the LRNC is very different in the 2 cases, and therefore there is about 70% difference in the drop of the FFR across those lesions. So you may say, well, this is a nice concept. How do you know if it's true? Well, we know that it's true because we looked at it. How did we look at it? We look at the comparison of the prediction of biointegrated FFR model to the actual ground truth of invasive FFR. What you see here is the blue line on here is the actual invasive FFR, and the yellow line or the orange line is the prediction. And you can see in the presence of a necrotic core filled tight stenosis, they follow each other very closely. But it's not just a necrotic core type of plaque, it's also a calcified plaque, as you can see here. Is also a mixed plaque, as you can see here, is a non-obstructive plaque that is calcified, and any type of a tandem lesion with multiple drops. And that led us to discovery in our test set that our performance in terms of sensitivity and specificity for binary detection of FFR positive and negative at the end of each vessel is very high, above 90%. But more importantly to me as a clinician, how it traces the actual truth in every point of the vessel is extremely accurate. with the LOA of 0.24. What that means is that the average error between the BioIntegrated FFR prediction and an invasive FFR is 0.05. To give you a ballpark of what that means, if a person goes to cath lab and Dr. Kamaj does the first FFR and is not, it wants to do a second point to make sure that that number is completely okay, within 10 minutes, the average difference between the first measurement and the second measurement is 0.03, 10 minutes apart. What we are seeing here is 0.05 difference between a non-invasive prediction and an invasive prediction because of BioIntegrated FFR. That brings me to the second point on the reliability of delta, which is the reproducibility. Reproducibility in AI tools is very important. We've looked at this in different parts of the vessel, different parts of the lesion, different components such as the calcified plaque, lumen, total plaque volume, vessel volume, and non-calcified plaque. And as you can see, pretty much at every point, our reproducibility is above 90s. We also looked at, for the first time in literature, look at the reproducibility for the LRNC itself. As you know, LRNC are very important, but very small components. Now, when you have a small component, the reproducibility is not that great, because if you go from, for example, 2 millimeter cube to 5 millimeter cube, you have more than 100% error rate. What we saw here is that in clinical categories, we have a more than 98% reproducibility for LRNC. And if you go with a binary cutoff of detection versus no detection, in every lesion is more than 98% reproducible. The last part of this reliability is transparency. And I think this is the strongest suit, aside from the accuracy part, of Elucid. We don't just give you a 3D nice cartoon of FFR. We tell you the entire story of how we got there. So you could go to the 3D viewer, you could say that I want to actually see the vessel for myself. In the same software, you can do the reading. Then you can add the Elucid contours of segment and of the lumen and wall. You see how we define the plaque, how we define the wall. You can push a button and the plaque analysis will come, and as you can see, both in the cross-section and in the curved MPR, you can see the plaque analysis. Push another button, the FFR will come, and the FFR pullback curve with point-by-point numerical FFR will come, and push another button, and a lesion tool will come that, quote-unquote, removes that blindfold, puts the anatomy, physiology, and morphology all together. So you'll see the lesion length, you see the FFR-CT, you see the total plaque, and Dr. Kamaj will talk more about that as how that can guide intervention, both in terms of decision-making, whether or not you want to intervene, and planning if you wanted to intervene. And there is a view for a person who needs to make a report that tells you all about the total plaque, the FFR, and stenosis in the software. I'll invite Dr. Hadley, the head of imaging at Northwell, to come and continue with our vision of personalized therapy.
Thanks, Amir. Thanks, everyone. Nice to see you. My name is Michael Hadley. I'm going to pick up where Amir left off, and I want to talk about not just what we can do with coronary CTA and plaque analysis in 2026, but what's the future that we really want to build together over the coming years? What are the steps that we need to take to get there, and how can Elucid help us with that? And that fits within this diamond of personalized therapy that Amir presented. And here we're talking about next generation personalized risk assessment, about next generation personalized therapy, both medical and targeted invasive therapies. And we're going to talk about those steps over the coming slides. Let's start with risk assessment. So, typically in 2026, these are the kind of things that we're looking at on plaque analysis to get a sense of a patient's risk. Things like total plaque burden, plaque subtypes, the calcium score, the CAD-RADS category, the presence or absence of ischemia, et cetera. But I'm going to argue that we need to move towards a lesion-level risk assessment to get more personalized, more targeted. Why is that? Because lesion is where risk becomes an event, right? So if we think about reverse engineering an MI, and we all know this, The most proximal step where all of these different risk pathways converge is at the level of a plaque, of a high-risk plaque that's at risk of rupture or erosion. And it's before that we have atherosclerosis progression and formation and all of these other individual and environmental risk factors that ultimately converge on that plaque. And of course, each of these have their own treatment pathways, lifestyle behavior changes, medication, targeted PCI therapies, et cetera. But it's really this lesion level risk that's going to lead us to an MI. If we can get to assessing a patient's lesion level risk, then we should be able to sum this up, incorporate all of this lesion level information to get a global sense of a patient's risk. We can combine that with other independent predictors like genetics, for example, to really get that global assessment, that next generation risk personalization. And then that's going to be what guides our personalized therapies. And this is true in the cath lab as well. I'm not a cath guy myself. We'll let Anton cover that. But when we send patients to the cath lab in 2026, a lot of the time we're doing it not because of lesion level information, but because of symptoms, because there's myocardial ischemia on some functional imaging test, maybe the FFR at the end of the vessel is less than 0.8. But we're not necessarily going into the cath lab knowing that we have a target for revascularization, right? All of this, again, both medically and invasively, comes down to lesion level risk. If we can get that, we could put patients on a 2x2 like this. On the left, we've got lesion level risk, on the bottom, procedural risk, and do a better job getting that sweet spot of sending patients who are going to benefit from revascularization who don't have significant procedural risk. So how are we going to do this? How do we quantify the risk of a single lesion? And this is where the AI Predict study comes into play. So this is Elucid's upcoming study. We're really excited at Northwell to be enrolling some patients in the coming weeks into this study, and I think a number of you in the room probably are also participating. This is a retrospective case control study. We're going to have 170 patients who had a type 1 MI and also a coronary CTA in the year or two before that MI. And then we're going to match that with patients who have CAD but who didn't have an MI, who also have CTAs in the past couple years. We're going to look at the angiogram. We're going to see where the plaque rupture erosion occurred. We're going to match that to the CTA, and we're going to understand what are the specific features of that culprit lesion and compare it to the features of the bystander lesions and the stable lesions. And one thing Elucid's really strong at is combining all of this information using AI algorithms to parse out the importance of all of these different anatomical, physiological, and morphologic features. So we're really excited to see the results of this study. And then, once we have that information, we can draft it on top of the UI that Amir already presented, which is already a lesion-based platform, right? So a lot of these factors are things we're testing in AI Predict, things like the volume of lipid-rich necrotic core, the mean luminal area and diameter, et cetera. So hopefully, the next generation not only will tell you the information about these lesions, but will also be able to quantify their risk. So that's risk assessment. The next step, of course, is management based on this risk, and that's where the HALT series comes into play. So this is a set of 6 different cohort studies, each testing a different combination of medical therapy to look for an endpoint of plaque progression. So all of the patients in these studies will have an index coronary CTA. They'll be started on one or multiple preventive therapies. They'll be followed for a couple of years. We're going to repeat a CTA, and we're going to see if these medications had an impact on the plaque and on all of these different plaque features that we're measuring. So the 6 different sub-studies are the core study, where we're randomizing patients 1-to-1 to lipid-lowering therapy, guideline-based LDL less than 70 and LDL less than 40. There's the HALT inflammatory study, randomizing patients to just LDL therapy alone versus LDL plus colchicine. The metabolic study, randomizing patients to lipid-lowering therapy versus lipid-lowering plus GLP-1. The Lp(a) study, same thing, but now we're doing it with lipid-lowering therapy. SGLT2 as well, and finally, antiplatelet with the baby aspirin. And we'll be looking for this primary endpoint in all of these studies of quantitative assessments of plaque progression, morphologic changes versus baseline. And when we're doing this, we want to make sure that we're accurate, that our results are reproducible. And that's the third piece, the evolution IQ study, where we're going to be taking sets of serial CT scans on individual and running it through the Elucid algorithm with a human in the loop multiple times just to ensure that these results are reproducible. And the last piece is the effect of local therapies, talking about targeted, some experimental, local invasive therapies. And that's the topic of the GUIDE IQ study. And I'm going to let Amir come back and lead us into that. Thanks so much.
Thank you, Dr. Hadley. So before I move on, I just wanted to say if anyone in the room is interested to be part of these studies, open invitation, please come and see us and Carol Hold in the first row for having a chat. And we actually do have a PI meeting for AI Predict later this afternoon at 3 o'clock. You're more than welcome to join. As you see here, the shape on the top is forming. That is what we care about the most, the patient, the outcomes. But parallel to that, there is also a very important focus, which is the workflow efficiency, which is what makes us to be better doctors, which is what makes us to be more efficient in our day-to-day so we can serve our patients better. We have a laser focus in Elucid on the workflow efficiency, which we define it by rapid turnaround time, efficient reporting, and seamless clinical integration. So I just wanted to talk with a couple of slides about that, how we are approaching that, and then give it back to Dr. Kamash to talk about the interventional aspect of how we use the Elucid software. So the first thing that I wanted to talk about is the whole UI design. The UI is designed in a sense that it could be complicated, but it could be very simple. I think about it more like an iPhone. Your iPhone, many people have iPhone or other types of smartphone. The device is the same, but the way that you use it is very different than the person next to you, and you personalize it to yourself. There is that vision in designing this UI, that if you think about it, a busy clinician in the clinic can only focus on the top part here. A cardiologist that is supposed to read the images, or the radiologist that's supposed to interpret the images, can focus on the middle part, and the interventional person can focus on all the other aspects that Anton will show you with the FFR pullback curve and whatnot. And our report exactly translates that. So the first page of report is a summary, that on top you have the highlighted information. We are very true to our lesion-level philosophy here, and we have the lesion of clinical interest and why we are interested in them. Is it the stenosis? Is it the FFR-CT? Is it the delta FFR? Is it the plaque? Or is it a combination of all that we are flagging them? So that the person in the clinic that just looks at the report with literally under 20 seconds of glance can figure out which direction is this patient conversation going to be. The second page of report is a 3D viewer of FFR-CT and a 2D viewer of a stenosis, followed by a very comprehensive table that segment by segment give you the stenosis, give you the FFR delta, as well as the plaque type and overall plaque burden. And the third page onward is mainly for people like Dr. Kamash here who want to take the patient to cath lab. That is a combination of a straight MPR, FFR cave, and a lesion tool. We have 4 different outputs. The first one is a UI that I show you. The second one is a structure output that I just show you, a structure report. But then the third and fourth is pretty interesting. So we have something called DICOM-SR, which is a machine-readable format that brings pretty much every information that is in the report into a format that is readable by a machine. Why is that important? Because then you can use AI, and we provide that, to translate that to your customizable reporting system. So the workflow that is designed for the physician is that you see the case, you send to Elucid, a couple hours later, you get the images with the full report back, and then there is your customized automated report available to you that you need to review, make sure that you agree with, and then you sign and you're done with that case. Now, going back to the last piece of the puzzle here, I want to introduce my friend and colleague from Mount Sinai, Dr. Kamash, to talk about a glimpse into the GUIDE IQ studies. and how we use series of Elucid images to actually decide and guide for treatment.
Okay, thank you, Amir, for the kind introduction. If I could summarize just kind of what's happened in the last several minutes, Amir was able to highlight all of the wonderful features that Elucid offers in its current iteration, as well as how we got here. And Michael was able to kind of give us a sense of where Elucid is going. I get to show you how we can apply Elucid currently to patients today, and I'll do so by showing you guys two cases. So case number one is a 48-year-old gentleman with shortness of breath on exertion, preserved ejection fraction. His LDL, you can see, was 86. His A1C is 5.5, and he does not have a diagnosis of hypertension. So this is going to be a discussion about medical therapy versus revascularization. So here's our initial image, and you can kind of see the entire coronary tree here and an eleocranial projection. And you can see the different colors here, and we'll talk about what those all mean, or I think it'll become very clear what those mean. And here's the, here's what you get from Elucid. So you're looking at this patient's analysis, and the first vessel we're looking at is the RCA, it's lesion number 1. And if you look here, there's a kind of a red plaque right in the middle. That's what we're zeroing in on. And what you can appreciate there is there's not a lot of calcium if you're, can I point with this thing? Yeah. There. There's not a lot of calcium there, but there's a lot of LRNC, which as an interventional cardiologist, I had to really look up these abbreviations earlier. It's lipid-rich necrotic core. And you can see there, you can see what the lesion length is, and you can decide what should we do about this. So you can look to see what the FFR reading is, and that is, it's all red, so it's less than 0.8. And you can see the lesion length, the lesion diameter here, and you decide what do you want to do about this. So if this is a patient with symptoms in this lipid-rich necrotic core, very stenotic lesion, I think most people would probably be in favor of revascularization. Now, of course, revascularization also includes bypass surgery, not only PCI. And so if we look at the CT-FFR pullback, you can see here that there's the dramatic drop-off when you're going across this lesion. So it tells you this is a very focal lesion, hemodynamically significant, and with a ton of lipid-rich necrotic core. So very high-risk plaque that's hemodynamically significant. Now, if we go to the LAD, we see something different, particularly when we're looking at the we're looking at the CT-FFR. And while the CT-FFR is 0.85, it's borderline, you can see that there's no clear drop-off across the lesion. So this seems to signify this is probably some long diffuse lesion that may or may not be causing the patient trouble. And so in a case like this, as an interventional cardiologist, I'm not jumping at the bit to put some sort of stent here. One could make the case that this is probably best left to medical management. Other things you could think about, of course, include placing a lima if you think the patient's very symptomatic, that when you can bypass the entire vessel. And in some scenarios, maybe you consider drug-coated balloon, although the data isn't really out to support that currently. So here's case number 2. This is a 65-year-old man with typical chest pain. His LDL is 101. His A1C is 6.7%. He's hypertensive, but that's under control. So here what you can appreciate, again, you can see the coronary tree on kind of both images there. You can sense that you might think that this is a lot of calcium. At least in my initial impression, I was like, oh wow, this guy has a very calcified vessel. But I think this is all blooming artifact, and I think it's pretty apparent as you kind of go across the vessels here. And when you do the plaque analysis with Elucid, you can see that the calcified plaque volume is very low. I think it's here, it's about 52. But a lot of it is non-calcified plaque matrix. But the CT-FFR is positive at this lesion, and there's a big step off there. And what we can see here is we have a distal lesion mean diameter, which is what we usually use to size our stents, as well as a proximal lesion mean diameter. So the distal lesion, I think, is applying to distal stenosis here, by the way. So how do you put this together? Let's say we're taking this patient to the cath lab. Vessel 2.0, we're not really excited about putting a stent in the 2.0 vessel, but that may be something that you leave to aggressive medical therapy, maybe something that you leave for a drug-coated balloon down the road as more and more data come out for that kind of thing. If you're looking at the more proximal vessel, there you have a 3.1 millimeter vessel. Now that's something that we could definitely put a stent in, and if you're really thinking that this very tight lesion here is causing a lot of symptoms, we know it's hemodynamically significant, maybe not with some high-risk features in terms of lipid-rich necrotic core, that's something we could very easily put a stent across, and you have lesion length here from healthy segment to healthy segment, about 38 millimeters. We definitely have stents that long, and we definitely have the diameter. So it's certainly something that we could fix in the cath lab. And now again, if we look at this distal, if we zero in on this distal lesion, you could see the CT-FFR is positive, but again, it's a very small vessel. So as an interventional cardiologist, I can plan ahead and know, okay, when I get in the cath lab, I'm probably going to leave this alone, but I'll definitely want to fix this more proximal lesion, at least with the kind of current status of how we practice interventional cardiology. So again, here I think we're looking at the circumflex. And the circumflex you can see is hemodynamically significant. The CT-FFR is very positive. It's a very focal lesion, but it's all pretty much non-calcified matrix. There's not a lot of high-risk features. There's no calcium. But now we're looking at the vessel diameter, and the distal lesion mean diameter in image is about 2 millimeters, and proximally it's about 2 milliliters. So that's also a small vessel, as far as I can tell. And so what do you do about something like this? In the cath lab, you can consider various things. Again, not eager to place a 2 millimeter stent, but you could try aggressive medical therapy initially. If symptoms persist, you could say, well, maybe we bring them back to the cath lab and treat this with a stent, or enroll them in a trial that's looking at drug-coated balloons and small vessels, things like that. And then here is an RCA lesion. Again, same patient, triple vessel disease. You can see CT-FFR is pretty positive here in this kind of proximal window that shows a lot of non-calcified matrix as well. The vessel here a little bigger than the last one, 2.8 millimeters distally, 4.7 proximally. And so you can see there's a lesion kind of here proximally, and there's some stuff going on distally there. Proximally, I would say this is definitely something amenable to percutaneous coronary intervention. And if you go here a little bit more distally, again, you still have vessel diameter here, a 3.0 millimeter vessel. You could place a stent here as well. And I think that's all for this case. So I think overall what we learned from these two analyses as to how we can apply them to patients in our current everyday practice, for some you could say there's something here that's very easily and readily fixable in the cath lab. There's something here that's probably best left to medical management. And there's some other things here where we could maybe look into more investigational therapies, or also involve our cardiac surgeons who may offer a bypass to a more long diffuse lesion. So a lot of useful information, at least from an interventional cardiologist perspective. And I think it saves us a lot of time in the cath lab. This would otherwise be something where you have to bring a patient to the cath lab, do CT-FFR down each of the vessels. It's a different wire for each one, and then go from there and have a whole conversation with the referring cardiologist, with yourself, with the cardiac surgeon. I think this really bypasses a lot of that and allows us to really streamline how we treat these patients. So I think it's a very valuable tool to have in our toolbox, at least in a more modern area of PCI. So thank you, everybody.
Thank you, Anton, for a wonderful presentation of these cases. Any question? That means that everybody is in agreement. Excellent. Well, thank you very much for coming, and enjoy the rest of your afternoon and evening. And if you're a soccer fan, today is a heaven.